Good afternoon, esteemed faculties and my dear colleagues. I'm Dr. Manish from Department of Urology, and I'll be presenting a combined clinical rounds on a rare urologic complication of acute pancreatitis in a young male. The case in point is a gentleman aged 29 years. He had presented to us in the casualty with the chief complaints of abdominal pain for the past 2 weeks, along with decreased urine output and uremic symptoms. He had history of hematuria, and he also gave history of daily alcohol consumption, more than 250 ml per day of country-made liquor. On further probing, he gave history of an episode of acute severe abdominal pain 6 months back, which was associated with nausea and vomiting. And he was evaluated at a private center, and an ultrasonogram was done, which showed splenomegaly along with bulky hypoechoic pancreas, which was suggestive of features of acute pancreatitis. Serum markers for lipase and amylase were done, and they were found to be elevated. His baseline serum creatinine was also within normal range, was 1. For these symptoms, he was further evaluated with a contrast-enhanced CT scan, which showed features of necrotizing pancreatitis with a CT severity index of 9 out of 10. And there were extensive peripancreatic as well as retroperitoneal fat stranding, as well as fluid tracking along the paracolic gutters. These are the films, and my radiology colleague will shed more light on these. He was diagnosed with alcohol-induced severe acute necrotizing pancreatitis, and he received ICU care for a week, and he was discharged from the private center in a stable condition and was being managed on an outpatient basis. And during follow-up visits, he presented with uremic symptoms around 5 months later from the index event of pancreatitis, and he was found to have raised serum creatinine of around 3.3 milligrams per deciliter, which prompted them to investigate further. A non-contrast CT scan was done, which showed bilateral ureteric dilatation along with hydronephrosis. Right-sided ureter was dilated up to the S3 vertebral level, and on the left side it was dilated up to the L5 level. And there was a residual pancreatic tail collection, which was of around 11 into 6 centimeter in size. There were no obstructing calculi or any other pathology seen. Patient continued to have progressive rise in the serum creatinine levels, and his creatinine level reached up to 16 milligrams per deciliter within a matter of few weeks, and that prompted for multiple sessions of hemodialysis, which he required on a twice weekly basis. At that center, a bilateral DJ stenting were attempted, but it failed because there was a complete cutoff at the lower ureteric level. They also attempted ureteroscopy, but they couldn't find anything beyond 1 or 2 centimeter of the distal ureter. Even bilateral ultrasound guided nephrostomy placement was attempted, but it also failed. So he presented to us with diffuse abdominal pain and decreased urine output. And on presentation, his vitals were 130, blood pressure of 139 by 97 mm Hg and a pulse rate of 96 per minute. He had features of fluid overload, and he also had tenderness and fullness in the left flank region. So we made a provisional diagnosis of a post-acute pancreatitis bilateral ureteric stricture with acute kidney injury with failed DJ stenting and PCN placement. So we ordered a non-contrast CT KUV for this patient, which showed bilateral moderate hydroureteronephrosis. And there was a large perinephric hematoma of around 7 into 10 centimeter, which was probably the result of the failed nephrostomy placement. And there was also moderate ascites along with residual pancreatic fluid collection. So we did a cystoscopy, and we also attempt retrograde pylography. We found complete block at the distal ureteric level, around 2 to 3 centimeter beyond vesico-ureteric junction. Even a small guide wire could not be negotiated across the narrowing. In view of this failure to place DJ stents, we placed bilateral ultrasound guided nephrostomies. And following PCN placements, patient had gradual decline in the serum creatinine level and required regular maintenance hemodialysis during this period. And over the course of next few months, the frequency of dialysis decreased gradually. And at present, the patient is off dialysis with another serum creatinine level of 4.5 milligrams per deciliter. Bilateral nephrostomies are in place and they're draining around 1 liter of urine from each side per 24 hours. And we ordered a nephrostogram study in which we place contrast through the nephrostomies, and they showed bilateral strictures on the right side till the S3 level and on the left side reaching up to the L5 level. So the further management options for this patient who has a bilateral lower ureteric strictures post pancreatitis, we have a few management options in mind. One of them is bilateral ureteroneocystostomies, in which we reimplant both of the ureters to the bladder. Or we can do is bilateral Boari flap ureteric reconstruction. Or we can do is a common channel transureteroureterostomy and reconstructing with a Boari flap to the common channel. Reviewing the literature, we could find only 2 case reports in which bilateral ureteric obstructions occurred secondary to acute pancreatitis. One of them involved a necrotic obliteration of the ureter due to enzymatic degradation, and the other one had a pancreatic pseudocyst which led to extrinsic compression and further on led to ureteric obstruction. From our institute, this was the first case report in 1994 from Professor Amlesh Seth, in 1994 in the Indian Journal of Gastroenterology, in which we reported a right-sided ureteric obstruction secondary to pancreatic inflammation, and that patient needed nephrectomy in view of pyonephrosis. And this study from Morehouse et al., they did a 5-year review of around 200 patients with acute pancreatitis and followed them up with the CT abdomen. They found that around 3% of such patients who have acute pancreatitis can develop a mild to moderate hydronephrosis and hydroureteronephrosis. And the involvement of perirenal facial planes is very common in these patients. And the inflammation need not respect any facial planes, and it can track onto the right side or on the left side. So coming to the pathogenesis of such strictures, these are all hypothetical pathogenesis. First that we see is extrinsic compression. This extrinsic compression can be due to a pseudocyst of pancreas which develops as a fluid collection and then subsequently compresses the ureter. These kind of patients can usually be managed with a double J stent placement and drainage of any pseudocyst if required. The other type is the necrotic obliteration of the ureter, which can be because of the enzymatic degradation of the ureter, because of the pancreatic enzyme tracking along the ureter and forming a sheath around the ureter. And that can subsequently lead to fat necrosis and calcification of the periureteral tissues. And the spillage of these enzymes can usually be during the formation of the pseudocyst only, or it can also be complication of a drainage procedure that is being undertaken. And these patients usually require a complex management in the form of PCN placement first, followed by a ureteric reconstruction in the form of ureteroureterostomy or a ureteroileoplasty or a Boari flap reconstruction. So this is a basic flow chart for pathophysiology: injury leading to pancreatitis and spillage of contents and fat necrosis and fibrosis. We also have prior experience in these ureteric strictures, And we had one gentleman aged 57 years who had a left lower ureteric stricture post pancreatitis episode. And we went on and did a excision of the necrotic segment and a ureterostomy end to end. And convalescence was uneventful for this patient, and a follow-up renal dynamic scan showed non-obstructive clearance of radiotracer on that side. So the questions that still remain unanswered are only few patients who have severe acute pancreatitis continue to develop these strictures. We could find only 25 case reports of these strictures developing, complicating episode of acute pancreatitis. And why do these strictures develop at specific sites along the ureter? Why on the right side or why on the left side? And is there any correlation between severity of pancreatitis and development of urological sequelae? So these questions will be answered at a later point. So to summarize, post-acute pancreatitis, ureteric obstruction can be associated with significant morbidity and a rapid decline in renal function. Although considered rare, up to 3% of patients can have obstructive uropathy changes on cross-sectional imaging, and a careful ultrasonogram follow-up of upper tract should be undertaken in such patients. I'd like to invite Dr. Sandeep Malla from radiology. He'll shed more light on the imaging findings of this patient.
Thank you, Dr. Manish. Good afternoon. So, this is a CT scan of this patient, which was dated July 2019. So here, this is during the phase of acute pancreatitis. So we can see extensive inflammatory changes in the anterior pararenal space, in the retroperitoneum, and on pararenal space in both sides and in the pericardic area. So these are all extensive inflammatory changes in the RP post pancreatitis, and these are the bilateral kidneys at this time point, which do not show any hydronephrosis. This is a CT section in the just below the level of the kidneys at the level of ureters. So this is the expected location of the ureters, which are not dilated at this time point, and there is some inflammation which is seen along the course of the ureters, where the normal course of the ureters is expected. So there are some inflammatory changes noted in the retroperitoneum. So this is the subsequent CT almost 5 to 6 months later. This is a non-contrast CT KUB. So in those coronal images, we can nicely see that there is bilateral moderate ureteronephrosis, and then there is a cutoff noted almost in the lower third of the ureter on the right side, and at almost L5 level, it was seen on the left side. And these are the axial images which show moderate hydroureteronephrosis. So then subsequently this bilateral simultaneous contrast nephrostogram one was done in July 2020, which also showed even at 15 minutes there was no passage of contrast into the urinary bladder, which suggestive of complete ureteric strictures bilaterally at the level of S3 vertebra on the right side and L5 vertebra, lower border of L5 vertebra on the right side. So based on our radiological findings, it was because the hydroureteronephrosis was persisting almost a year after the episode of acute pancreatitis. So it was suggestive of bilateral ureteric strictures likely due to acute pancreatitis.
Now I'd like to invite Dr. Atul from gastroenterology regarding pathophysiology of acute pancreatitis and its sequelae.
Thank you, Manish. Yeah. Coming to the introduction of acute pancreatitis, it's an acute inflammatory disorder of the pancreas, which starts from the premature activation of trypsinogen, and it leads to the inflammatory cascade, which may involve remote organs. It is associated with a significant substantial morbidity and mortality. The mortality over the last decades has significantly decreased because of the increase in the ICU care. However, it still persists up to 1.6%. The most common cause of acute pancreatitis are gallstones and alcohol use. The diagnosis, the famous Atlanta criteria used for the diagnosis of acute pancreatitis, it include 3 criteria, out of which 2 has to be present for the diagnosis of acute pancreatitis. The first one is the symptom consistent with the pancreatitis, which is the epigastric pain radiating to the back. However, around 10% of these patients could present in painless form. The second criteria is elevated serum amylase or lipase level, and the third is the consistent radiological imaging. In 2012, the revised classification of acute pancreatitis was given, which included acute pancreatitis was divided into 3 categories: mild acute pancreatitis, when there is no organ failure or no local complication; moderately severe acute pancreatitis, when there is a transient organ failure which lasts for less than 48 hours with or without local complication; and severe acute pancreatitis, when there is a persistent organ failure which lasts for more than 48 hours and with or without local complication. The organ failure may include AKI, ALI, and circulatory shock. From the point of radiology, acute pancreatitis is divided into 2 types: interstitial pancreatitis and necrotizing pancreatitis. In interstitial pancreatitis, there is no necrosis of the pancreatic tissue, which is on CCT will find a normal enhancing pancreas. So usually these interstitial pancreatitis, they don't have any local complication. When they have local collection, and when these collections are less than 4 weeks old, and these are known as acute peripancreatic fluid collection, and after 4 weeks they develop a well-defined capsule and they turn into pseudocyst. And whenever there is a necrosis in the pancreas after episode of acute pancreatitis, and most of these cases have necrotic collection, and when these collections are 4 weeks old, they are known as acute necrotic collection. And when these collection after 4 weeks, they develop a well-defined granulation tissue around its wall, then it becomes wall of necrosis. Coming to how this collection forms, this is okay. So this is the sagittal section of human anatomy with peritoneal anatomy. So this, you can see, this is the greater sac, and the red color is the greater sac and the blue one is the lesser sac, which communicate through the epidural foramen. This is the lesser omentum, this is the greater omentum. So you see here, this is the pancreas. It is related very near to the, which it's a retroperitoneal organ and lying adjacent to the lesser sac and behind the stomach. So whenever there is a pancreatic inflammation, the inflammatory process, all inflammatory mediated, they can go into the lesser sac and form lesser sac collection because it is lying directly adjacent to the lesser sac and may involve stomach. It is very closely related to the duodenum here, so it can involve the duodenum, cause duodenal strictures and gastric outlet obstruction. From the mesocolon, it can extend up to the transverse colon and may cause stricture of the transverse colon or maybe fistulization. And through the mesentery, it can involve the small bowel, and from here through the anterior pararenal space, it can track down to the both paracolic gutter till the pelvis anterior to the psoas muscle can lead to the paracolic gutter collection. And this is the transverse section. You can see here the pancreas is lying very close to the kidney and just separated by the anterior pararenal space. So usually this collection can be symptomatic, can be asymptomatic. Whenever they are symptomatic, they either present with pain, infection, gastric outlet obstruction, fistulization, obstruction of bowel, and hydronephrosis. Hydronephrosis, as Manish has told, that it's seen only in 3% of patients, and most of them resolve either with the drainage of the collection or as the process evolves. So likely pathogenesis of these complications are either pressure necrosis from the inflammatory debris or inflammatory process leading to the surrounding tissue digestion, or ischemia related to the vascular thrombosis of the small vessel. And pancreas itself is immunosuppressed state, so maybe the reactivation of VKV virus could have led to the ureteric stricture in this patient. And coming to the management, not all collection need to be drained, only symptomatic collection are required drainage, and the type of method of drainage depends on site of collection, duration of collection, and available local expertise. Most of the symptomatic collection, they have either proven or suspected infection, so they require antibiotic coverage, and whenever these collections are less than 4 weeks, they are usually drained by percutaneous drainage, when there is no improvement despite maximum supportive care, and after 4 weeks they are either managed by step up strategy of bone, which include either endoscopic or percutaneous drainage followed by endoscopic or percutaneous necrosectomy followed by minimal invasive surgery, and pseudocysts are usually drained by transmural or transpapillary drainage. Thank you.
Good afternoon, everybody. Involvement of the urinary tract is a very rare complication of the acute pancreatitis. Till now, only 27 cases has been reported in the literature. In our department, we have reported total 5 cases. First was in 1994, and other 4 cases was in last 3 to 4 years. Management of this type of the cases usually depends on the mechanism of hydronephrosis, mechanism of the ureteric obstruction. We all know there are mainly 2 mechanisms. First one is due to the mechanical compression from the outside due to the pseudocyst formation. In this case, the case can be managed simply by the placement of the PCN tube or DJ stenting and drainage of the pseudocyst. The other mechanism in which there is a direct involvement of the ureter that usually requires surgical, definitive surgical management. In series of 5 cases, we did simple nephrectomy in 2 cases because both were presented very late, and at the time of the presentation, the kidney was non-functioning. In third case, the hydronephrosis was managed by PCN placement, and pseudocyst was drained by just external drainage. Fourth case, in which the stricture was present in the left side lower ureter, that was managed by initially managed by the PCN tube placement, and after 4 to 6 weeks, we were lucky to succeed by in-to-in ureterostomy. And the 5th case, which that is already presented today.
What is the current grade? 4.5. 4.5.
Yes.
This is 1 year after the onset of illness.
So around 1 year.
What is primarily reason that normally osteopathy should have recovered the renal function reasonably well if it is intervening time in terms of the bypassing of it?
Yes, you're right that his creatinine is 4.5, and with this 4.5, although his urine output is good, he's passing almost 2 liters, 1 liter per side. I don't think any major reconstruction will be possible. Creatinine of 4.5 is quite bad. And this young man has really been quite unfortunate. He's only 29 years old, and he developed bilateral ureteric strictures. And when the creatinine was 3.3, that was the time to intervene. As soon as it was picked, it should have, but the patient was not managed, and he was allowed to go into an irreversible kind of a situation. His dialysis was started when his creatinine went up to around 14 point something or 15 point something. And even at that time, although he had relatively easy percutaneous nephrostomies, I mean, that was not done properly. He'll end up with a large retroperitoneal hematoma, and he'll end up in the emergency in a very sick state. He was septic, he was azotemic, and he was oliguric, and some of the other, he could be salvaged. He's kind of salvaged, but he is obviously in a bad state. With 4.5 creatinine, I don't think any major reconstruction will be possible.
At the time of acute stage or the subacute stage, when there was stricture of the ureter, was the retroperitoneal was also found inflamed on radiological investigation, or only the ureter was?
No, by the time actually his features of acute pancreatitis had subsided. He had acute pancreatitis in July 2019, and the complications, the urological complications started in December 2019. So there was a gap of about 5 months, and at that time his amylase was normal. He was, in terms of his GI function, he was all right, but both his ureters and the inflammation caused, and sometimes the strictures are very, very bad. Pancreatitis can actually completely digest the tissues and lead to replacement of normal tissues with fibrosis and calcification. Any other questions, comments? IgG4, this is not the picture of IgG4 related disease. IgG4 is a separate disease by itself, and this is patient definitely had alcoholic acute pancreatitis, had severe acute pancreatitis. The CT picture is of severe acute pancreatitis, and as has been discussed, we have seen 5 such patients in the last about 25 years, and they all have had bad strictures. The only one patient was lucky enough that it could be managed without any surgical intervention. 2 patients land up with nephrectomy. 1 patient is in bad stage. Only 1 patient could be salvaged with end-to-end anastomosis of the ureter. So overall, I think it's a bad disease, and the follow-up after severe acute pancreatitis should be more close, and so that patients can be salvaged with early intervention. Dr. Piyush, any GI comment? Okay. Yes. Thank you, everybody. Thank you.